who requested to join our case by case. We have students from IMU, Monash, USM, Newcastle, even some HOs and a few doctors from KKM. And if I'm not mistaken, today I actually got a few emails from Shanghai, like 4 or 5 students. So if you guys are on this call, pleasure to have you on board. Yeah. Wow. Okay. Yeah.
Oh, you're starting to make me nervous now.
Even I. Maybe I should have mentioned that. Okay.
It's okay.
All right. So here, without further ado, so here we go. So this is our first case. Mr. Ahmad Prom, who is a 76-year-old man living alone for the past 3 years after his wife passed away. So he has a daughter who lives nearby and comes to visit weekly. Drives himself to the nearby coffee shop, walks unaided. Daughter claims he has very few friends, and he has a rather irritable temper whenever he is reminded to take his medication. So his daughter was called by the neighbor. As they said, Mr. Ahmad was very aggressive, accusing his neighbor of spying on him and plotting to steal his belongings. Okay, so I guess, yeah, if, doctor, when we see such a prompt, or for example, a patient that presents like this who is irritable or aggressive, like what would be the first few things that maybe come to your mind?
Yeah, I think to start off cases, I just want to explain now, because today you have a geriatrician here, so you have an older person's case first. But I think it is very important to understand what might be normal and what might not be normal in older person. So I hope that, coming to this series, or even after finishing this series, it will also encourage students to understand that older person is just like you and me. If something is not normal that you won't do, don't think that, it is normal for an older person to do. So you don't think that, oh, well, they're old already, they're usually grumpy. Hence, if a patient like this goes to see a GP, not to say GP, or any doctor, some might think that this is very normal, well, they're just getting old, and it's fine, just go home and, just look after him a little bit more. So I think it's important to understand, is this normal for him to behave in such a way? I mean, for some people, it may be normal, they're just generally grumpy, therefore, anything also actually makes them upset. If the neighbors put a pot just outside or park the car just outside your house, they might be upset. So you need to understand if this kind of thing happens, is it normal or not normal for the patient? So I think that's the first thing that you need to do. So that's why we said, when you clock any cases, when you come across any patients, make sure that you take a very good history. So in this case, this highlights that you need to understand the case a little bit more, the patient a little bit more, for you to determine whether it is important to further investigate, to probe deeper, or you think that it is fine, it's okay. Yeah, so I think that's the first thing that we should do.
Whether to determine whether or not this so-called irritability is a normal thing or it's abnormal.
Yeah.
Yeah, because I guess, now that I look at it, because we came up with the cases together, so this is it's probably something. But if it's a normal old person, I would also think, this might be. It sounds like normal. It sounds normal to me.
Yeah.
When you think about it, So okay.
Yeah, I mean, because with older person, as you need to understand that, when something is wrong, sometimes it might just be that they're more irritable. They don't typically present with cases like, I've got fever, therefore, I've got a cough, therefore it's pneumonia. It's not always like that. And confusion, in a way, is very common in older person to present with, but it is not normal for them to be confused. Okay?
Okay. But with that said, in terms of history, before we go on talking about the history, doctor, how would you probe out exactly whether or not this so-called behavior is normal or not normal?
Yeah, I think it depends on, at the time when you are reviewing this case, who is there with you. We always encourage students, remember, whenever you come to see a case, see the case first. That means see the patient first. don't always, older person, I'll just go straight and talk to the relatives, their history may be more reliable. So try not to do that. Or actually, do not do that. Go and see the case yourself. Talk to the patient first. Introduce yourself to the patient. Talk to him. Get a little bit more history about what has happened. What do they understand has happened? If when they're talking to you, they are already exhibiting signs or symptoms that, this is not right. He seems really confused. Then you probably know that this is not normal, But if you talk to him and he really comes up with a valid reason why he's behaving like that, and he understands what is being asked, then it may put you through to a different diagnosis. So it's very important to go to the case that you're seeing, talk to the patient, get his point of what has happened. Then later on, you can get a bit more history from the daughter itself. So basically, if this problem with behavior, aggression, irritability, what you need to do is just as a normal approach to finding out why he's like that. Many times in medical school, we are being taught, okay, come in with chest pain, you go through all your cardiovascular history as how it is supposed to be. If you got pain, you must ask, where is the pain? What is the character of the pain? What makes it better? What makes it worse? In a way, it becomes very, very automatic that you don't think further, about how to get a good history. So what you need to do is really just talk to him like a normal person. Find out why is it like that. Ask the daughter, what has been happening? Why is he behaving like that? Has he ever behaved like that before? Has anything changed in the last few days? Has he been unwell at all or not? Has his medication changed? So there's lots of things that you can ask to help you come up with a plausible reasons of why he is irritable. Yeah. So the first approach is talking. That is what we do most, talking to find out causes. Yeah.
I see, doctor. Okay.
Yeah, and like as is usually said, history, taking a good history gives you about 80% of what the diagnosis may be before you do any tests or investigations.
Okay. All right. Thank you, doctor. Okay. Sorry. Before we go on, does anyone have any questions so far? If you can unmute your mics and actually ask, or maybe you can just share in the conversation.
Yeah. I mean, if you're very shy, then you type and ask the questions. We will try and answer as we go along. But if you want to, you can unmute your mic and ask the question as well.
Okay. Well, anyway, we don't have any questions so far. But if you do along the way, as we talk more about the history, go into the PE, just feel free to check the conversation. So for case one, I'll be handling it. So I hope Kenneth can help, just in case I miss any part of the conversation, just help me check it. And then wait. But because Kenneth will be leading case two, so after that, then we'll just be backing each other up. Okay. So now moving, so continuing on into the case itself. So furthering, as after the history was taken, so the daughter noticed that her father was quieter for the past 3 days and mumbling to himself. So he had a near fall when he was trying to get out of the car. Apart from that, also complained about muscle cramps that are intermittent for the past 4 days, and the frequency of the duration of the cramps have been increasing in both legs. Okay, sorry, I still have some people who are trying to get in. Okay, so so with this new history that we have gotten, do you think has the diagnosis been sort of narrowed down right now, doctor?
Well, I think because it's an older person, therefore there are certain things that the older person has or has changes in actually triggers an alarm bell in our head. So I think those who have gone for geriatric lectures will know that things like falls ring alarm bells in our mind. Things like acute confusion ring alarm bells. Things like incontinence, things like a change in medication or having side effect or having a lot of medication actually makes alarm bells ring in our mind. That will actually make us feel that something's not quite right. They may have what we call geriatric syndromes. And that means that, we have to probe further. We have to investigate further to see what may have caused this irritability that has happened. Because I think if the daughter has noticed that dad is actually quieter and starting to mumble to himself, which she finds it is not normal for him. That's why she would actually give you this kind of history. So when relatives or when patients gives you this history, you must catch on to that and try to probe a little bit further. Because if you give you a hint and you didn't take it as a hint, right, then you might miss the diagnosis totally. So things like, change in certain behavior that he is being a bit more confused, mumbling. No, that's not quite normal. And this thing about having a near fall, although he did not actually fall, but when the daughter says that he had a near fall, he was unsteady, and when he was trying to get out of car, then you'll be thinking, what is causing that problem? And the thing is that he does have a new symptom of some sort. So he seems to be having some discomfort in his body system. As I mentioned, in older people, especially the ones who may have cognitive impairment or has cognitive impairment, any changes to their body system, be it pain, constipation, infection, falls, any changes to their physical health can cause a deterioration in their mental health. The same like how would I advise patients who may have dementia, that I would tell the family members it's not about what medicine you can take to improve your cognitive function, but you need to ensure their physical health is good. Because if your physical health is poor, your cognitive function will decline. The same with this kind of cases as well. So it makes me feel that this irritability that he has may not be his normal self, and it is a bit unusual for him to behave like that, even though he may be a little bit grumpy, So you have to probe, okay, then find out what may be the cause of this muscle cramps and what can you do to help him about it. Yeah. So I think in this part, having this kind of history will make me think that, okay, this does not sound like it is just a grumpy old man, It sounds as though something is not quite right. Or you may find that actually, the signs are very soft, It's not as though he cannot breathe. It's not as though he suddenly cannot move on one side. This kind of cases, just watch and see. Which in a way, I have to say, many times these patients has a hint that something is wrong and it's not sorted out properly. It actually has a snowball effect to subsequent problems that they may have, which in a way that when they get admitted, they might have been in a much poorer state or may have been in a more acute situation where actually if you have sorted them out early, they may not have deteriorated to that point. Yeah.
I see, doctor. Yeah. With all this said, is there anything else? So, like for example, because now we know this sounds like a case of acute behavioral change because he only had he only had this. He became quieter over the last 3 days. So, like probably a first thing that might come to mind might be in an older person might be delirium, and in that case, when we're taking history, would we have to go through the whole list of risk factors that we asked about during?
I think you should. So basically, what you're looking at is that I suspect, in this case, delirium is very likely because they tend to be a fluctuation even in the behavior. It was quiet, and then suddenly there was an outburst of aggression. So that's not quite normal for a person to fluctuate that much. So there seems to be a fluctuation in terms of his cognitive function or his thinking, he may have some slight delusion for all you know. So if you think of it like that, and you try to take the history, somehow you want to see if there is any hints, because there's so many reasons or causes of delirium. You can't go through every single one of it. So you may want to see if there's any hints when you ask the daughter a bit more. So pain is one. So if he has muscle cramps, there must be some discomfort. So there is pain. So you'll be thinking, oh, okay, is it because of pain? And someone who has pain, you are very good at taking muscle cramp or pain history, right? So if he has pain, you'll be asking, is anything that makes it better? Is there anything that makes it worse? Then you want to know, has he been started on new medication because of the pain, or has he been taking medicine for the pain itself? How much has that bothered him? Some people, when they have discomfort, living alone, I just cannot be bothered. I don't want to do anything. I'll just sit down. They may get dehydrated, or they may, if they are diabetic, they may get hypoglycemia, or a lot of other effects can come on. So that's something that you need to understand. So falls, like I say, when you have near falls, you want to know, has he actually ever had a fall? He lives alone. Maybe he has, and he didn't tell anyone. Have you noticed any bruising or any laceration in the head? The doctor might say no, or any bruises elsewhere. So those are the things that you want to find out as well. And one thing, has this kind of incident ever happened before? Because if he says, last time when he was admitted because he had appendicitis or cholecystitis, he was also very confused, So that gives you a hint. Oh, okay, so this is something that's happened before, and this may be delirium because of other factors. Yeah.
But besides delirium, what else would come to mind? Of what else do we need to keep at the front of our head as well?
I think what you need to understand is what is the presenting complaint. So if the presenting complaint is an acute confusional state, acute change in behavior, so that constitute, especially in an older person, you'll be thinking that this sounds like delirium, okay? And if you are thinking that this is delirium, I think the most important thing now is not to think about, besides delirium, what else can it be? You remember all the 3 Ds that usually come together? You'll be thinking, maybe actually this may be dementia, or is it because he is depressed? So these 3 Ds will be something that comes into your mind now. Yeah. So, but if you just think that this is delirium, right, there is so much in terms of its causes that you need to consider. It is always safer to think that this may be delirium than not, because delirium can be detrimental. Delirium actually constitute an acute medical condition. So it's always safer for you to think, maybe this is really delirium, okay? Then think about all the causes and manage it as though it may be delirium itself. Because it's very important not to miss it. Dementia, you miss it, they won't die, in the next couple of months. Depression, the same thing, unless he presents his very depressive state, then you worry about suicidal intention. But if it's delirium and you don't treat it, because usually delirium is an acute medical condition, then the acute medical condition can spiral and cause more problems after that.
Okay, I see, doctor. Okay. So, all right. So with that said, shall we move on? Okay. So just moving on to, this is Mr. Ahmad's past medical history. As you can see, he has hypertension for the past 25 years, high cholesterol also, BPH, and he also has hypothyroidism for the past 8 years. So as you can see, as I understand, hypothyroidism can be a possible cause of confusion as well. Would this be something that we need to think about as well?
Yes. Any older person with confusion, behavioral change, remember you must do a thyroid function test, okay? Including your B12 folate thyroid function test, because it is easily treatable, and it is actually also more common in older person. I used to work for my boss previously, who clear-cut will do all these things in any confused patient. CT brain, thyroid function test, B12 folate is like a stand, I'm not saying you do that for all patients, but just remember that these are the things that are more common in older person. And sometimes they may not even have typical symptoms of hypothyroid. They might just be, a little bit grumpy. They might just be a bit slow, or they might just be a bit more tired, and they have quite severe hypothyroidism, to be honest. Or they might come in with heart failure, and actually you find out they have severe hypothyroidism. So it's important to check it. But if they have had their thyroid function test checked 6 months ago, then obviously you don't have to repeat it again. And let's say if it's absolutely normal. In someone who is not known to have thyroid problem. So that means you're doing it as a screening, but you check, 6 months ago had the test and it's normal, then it's fine. But in this case, if they already had a thyroid disorder, even if the test was 6 months ago, you want to repeat it again, okay? Because you don't know if he actually is taking his medicine or he's taking too much of that medicine, so that dysregulation of thyroid hormone can cause the outburst of the aggression.
I see. Okay. So that means he might be taking too much medication right now, and it's causing him to be more aggressive, is it? Is that what you're saying?
Be. There is always a possibility, so it's important to recheck it.
Okay. And what about regarding the B12 and folate tests that you mentioned? Why exactly are those tests important?
Well, have you heard of lots of old people? They will take B12 and folate because they were told that it can actually improve your nerves. But to be very honest, those B12, I mean, I'm talking about supplement, Neurobion or B12. They're not magic pills, their effectiveness is not great. But I have to say that, especially also in older people, we have seen patients with B12 deficiency and they're a bit more tired and they're a bit slower because it does have an effect to nerve function itself. But I have actually never seen any older person who have B12 deficiency alone sampai their cognitive function is really, really poor to a point that they have dementia. No. So yeah, but we do check it anyway because, like I say, these are all easily treatable. And in old people, you must remember that sometimes even when you find one abnormality that may be a contributing factor to their presenting complaint, don't just stop at one. Usually they are multifactorial. So let's say if this gentleman hypothyroid, and you look at their thyroid function test, it's only very mildly abnormal. You can't say that it's because of the thyroid. So it's usually not the case. It could be, yes, it could be a little bit because of the thyroid abnormality. It could be also a little bit about other things, a little bit about this other thing. So that contributing factor of it all happening at the same time may has caused him to present like how he is now. So make sure you continue to look for other causes of either acute confusion or falls or anything else pertaining to the older person. Don't feel too happy if his thyroid function test is only a little bit abnormal and you feel that, okay, it must be that. It usually is not just that alone.
Is it common for doctors or medical students to kind of miss a cause of the patient's presenting illness, then especially since you mentioned that it's usually multifactorial?
Yeah, very common, to be honest, very common. And sometimes when we diagnose patients, it also depends on what is our level of thinking at that time. So if that is your 15 patient that you're seeing, you are so mentally tired, you won't want to look for more things. When you look for something that mildly sound like a UTI, right? You will catch it. It's a UTI. That's it. But it may not be that. So in this case, you might also say, maybe he's got UTI. That's why he's more confused. So that's why it's very important to have an open mind when you're taking a history. When something sounds that it could be plausible, do not think that it is always that case, I mean, I'm not talking just in older person per se, I'm talking about generally in your history taking in any age group.
Okay, doctor.
All
right.
Well, we've got a very quiet group. Y'all can ask question when or if you feel you don't agree with anything, you can also type it down. I have very poor memory. I will definitely not remember who asked what questions.
Okay, or perhaps maybe they might have more questions by the end of the case. Yeah. Okay, so just gonna move on to the next slide. So here, drug history. So as you can see that recently his atenolol was stopped because he complained he had cold hands and feet, and he was switched on to a thiazide diuretic, and he had no problems after that. So other medications that he's on includes hypertension medication for BPH, thyroxine, and so on, aspirin and simvastatin. And also, so I guess, as I understand, I think from our geriatric lectures, is that drug history is super duper important, especially in geriatrics. So with that, I guess from my understanding of it is that because mostly a lot of elder people, they have a lot of concurrent problems, and they take a lot of medications regarding that. So perhaps like as a geriatrician, like how exactly what part of drug history, doctor, you would be focusing on when you're taking in order to kind of
Yeah, I think in a altered behavior presentation, or even a confusion presentation, obviously in different age group, you will think of different possible causes. Okay, so now if we're talking about an older person, then you'll be thinking about, could it be prescribed medication that has caused these problems? The more medication you take, the more likelihood you will get an adverse drug effects lah, you know. And certain medication in older person might be potentially inappropriate, and a combination of certain medication also may be the cause lah. So like in this history, this gentleman is taking two types of blood pressure lowering medication. So now that he's been changed to bendroflumethiazide, and he's also taking lisinopril. So you have two classes of antihypertensive. And not only that, he's actually also on tamsulosin. So tamsulosin is an alpha blocker. Imagine taking tamsulosin, alpha blocker, and an atenolol. No wonder he's getting side effects. So he's taking a beta blocker and an alpha blocker. Yeah. So at least the doctor has changed him to diuretics, bendroflumethiazide. But then again, when you take about 3 medications that can lower your blood pressure, you'll be wondering, you know, is this patient going to get postural hypertension or not? You know, how's their baroreceptors regulating the changes in blood pressure? Because you have a tendency to have an overreactive or actually insensitive baroreceptor. So therefore, that would be the first thing I'll be thinking about. But you know, diuretics, like your thiazide diuretics, can cause the commonest electrolyte imbalance in older person. And that one, Kenneth will be able to tell you what electrolyte imbalance is it I'm talking about. Okay?
Yes, Kenneth, what the...
What is it, Kenneth? I want to check and see whether you listen to the lecture or not.
Hypokalemia.
Hypo what?
Kalemia.
Kalemia, and what else?
Natremia. Hyponatremia.
Yes, yes. So we're talking about hyponatremia, the commonest electrolyte abnormality in older person. Okay, and most of the time, hyponatremia, the commonest electrolyte in an older person, is secondary to drug-induced causes. So your thiazide diuretics more likelihood than your loop diuretics. So if you've got a patient with bendroflumethiazide and furosemide, the bendroflumethiazide are more likely to cause hyponatremia. So there are lots of medicines that can cause hyponatremia. So if you look it up, right, you can see that's more than 20, 30 of them. Even PPI or omeprazole, your antidepressants, your SSRIs, your antipsychotics, even dimicron can cause low sodium, So there's lots of medication that can cause that. But the top ones are your diuretics lah. So I'll be thinking, I'm just wondering, how is his sodium level like lah? If he's just been started on the medicine. Yeah. So if they take 5 or more medication, then we call them polypharmacy. That means they take quite a bit of medicine. So you want to know that why they're taking this medicine. Do they really need it? Has there been a change in medicine? Because sometimes doctors change a medicine not knowing that they're actually treating the side effect of the previous medication that they've started. So they come on to this prescribing cascade. So be very careful lah. And as much as there's a whole long list of medication that he's on, you also want to know, is he compliant to the medicine? So he may be on all of these, but he may not take it. So if he doesn't take it, then, polypharmacy being cause of this could also be a cause, because polypharmacy or inappropriate taking medication could also mean not taking the medicine that you're supposed to take. Polypharmacy is not about not taking medicine, but non-compliance to medicine could be because you're not taking it at all. Yeah, so it's important. I have to say that when you start working, a lot of times, especially in the emergency department, so we've got a lot of emergency colleagues who who don't write down what medicine the patient is taking. So it's important to note it down. So like I say, if I look at this list of medicine, again, I'll be thinking, okay, there are a few factors also that rings my alarm bell.
So as you mentioned, Dr. Hyponatremia is a very common cause for confusion in the elderly patient, right? I think I remember like in internal medicine, probably one or two doctors has gone through hyponatremia, the concept of hyponatremia, with me, and I understood they separated into a few categories, and it's still a concept that's a bit difficult for me to grasp at this point. I initially wanted to put it in as a learning objective, but I felt that we won't have time to cover it as a topic.
Next time. We do have an algorithm. Actually, we came out. There was a internal medicine specialist who did hyponatremia as her master's thesis. So I supervised her when she was doing it. So she actually came up with an algorithm for the junior doctors to understand what kind of tests you should order and what type of hyponatremia has the patient got and how do you treat it. So if you think it's helpful, I can send it out to you and you can, disseminate out to everybody lah. Yeah. So the other thing you have to understand also lah, the degree of the hyponatremia. You can divide it into mild, moderate, severe. If this patient is suddenly becoming so agitated, and if the sodium is only 130, you'll be thinking, 130, can it cause that amount of aggression? Maybe, maybe not. But like I say, always have a clear mind. If the sodium level is 120, then you'll be thinking, oh, okay, this must have a lot to do with the hyponatremia. So that gives you some degree, of the severity of the hyponatremia and how far you need to investigate it also.
Okay, doctor. All right. Shall just move on next. So just moving on. So our patient is a retired accountant. He used to look after his wife for many years, and he's a non-smoker and he doesn't drink alcohol. And okay, that's actually it. Is that for social history, I guess? Is there anything else from the social history that perhaps would be important in this case, doctor? That was not.
Geriatricians love social history. But our social history is not just about independent walking or not, need to use a stick or not. I know, and then in the house, how many steps. I know, yes, we are interested. I find that every time when students come and present cases to me, because they know they're presenting to a geriatrician, sometimes the presenting complaint is already, this is an 86-year-old woman who lives in a house with a daughter, and they tell me all the social history, then only the presenting complaint. And not to say that when you are presenting to a geriatrician, you have to do that. Yes, we are interested in a social history, but then again, you need to also know what to ask in this case itself. So because this gentleman has acute change in his behavior and he seems to be a bit confused, that's why I am very interested to know what his baseline cognitive function is. So I would definitely ask the daughter, how is he coping at home? Because he lives alone, some of you who lives alone knows that you have to do everything on your own, kan? You have to buy food you have to pay the bills you have to clean the house or if you don't clean the house also, you still have to wash your clothes and do the laundry and fold the clothes, right? So there are still an amount of work that you need to be able to cope, to live alone. So if this gentleman was doing that, you may think that, okay, maybe he's cognitively very intact but then again, you want to know that, has there been a change? Is the house now very messy? Is he hoarding a lot of things? Is his fridge filled with food that has gone bad? How is he actually losing a lot of weight because he may not be eating well? So those are especially the things I want to know. How is he coping? I know he can drive. I know he lives alone. I know he walks without stick. I know his house is a single-story house, but how is he keeping up with his day-to-day activities? So those are the things that we want to know, because which we will discuss later, that to have acute confusional state, not everybody can have it, So sometimes it might be because they already have a low threshold to getting confused. Therefore, he's become confused now. So having a low threshold, that means his brain is a bit fragile. Therefore, when he's physically unwell, he can get confused very easily. So you just wonder that he may have other underlying chronic illness that has not been diagnosed. So in older person like his age, I'll be thinking, how is his cognitive function prior to this? Has he actually has an undiagnosed cognitive impairment that increases his which lowers his threshold to getting delirium when something is not gone right in his body system?
Okay, I see, doctor. Okay. All right. So I shall just proceed then.
Yes.
Okay. So now that we are done with our history, we're just going to proceed very quickly into physical examination. So in terms of Mr. Ahmad's case, perhaps what exactly should be done for him, knowing now that we know that he's coming in with an acute confusional state and he has muscle cramps, and also he has a quite significant drug history that we're thinking of. Apart from that, I guess.
Maybe we ask the students, they can type out, what do you think you would do when you see this patient? What kind of examination would you do?
Okay, let's see the conversation.
Okay, good. Yep. What else would you do? Anyone else?
I can't see the conversation.
Oh, you cannot? I can.
Oh.
Oh, wow. Okay, so Li Ziyong says that, look at the general appearance, do the vitals. Yes, if he comes in at the blood pressure of 190 something, it gives me different impression. Oh, why is he like that? Has he got hypertensive urgency? Has he had a mini stroke? What has gone wrong? Has he got a bleed in the brain that's make him to be acutely confused? He may have hypertensive stroke for all you know. Okay, wow, MMSC. Okay, if you do an MMSC in the emergency department, I will give you a medal. Because MMSC it's not really that lengthy, to be honest. It takes less than 10 minutes to do if you do it correctly. But there are other quicker screening tests that you can do in the emergency setting or in the acute medicine setting. And then later on, if the screening test is abnormal, then you can continue to proceed to do the MMSC lah. Okay, neurological examination. Why focus on the lower limb only? Why not the upper limb? I don't understand. Or is it because he had a near fall? Okay, but I would do both. I would do an upper limb examination. I would do a lower limb examination. I would do a very quick neuro upper and lower limb examination. Okay, this one also deserves a medal. Do the 480. Excellent. So the 480 is it's a test for delirium. I think we've got some slides about it, so I'll explain to you later. Confusion assessment method, very good. So for delirium, yes, you do a confusion assessment method. So this is a scoring system that as you take a history from the patient, you should be able to have an idea what the confusion assessment method score the patient has. Okay, so in any case, when you have someone who comes in with behavioral change, I would do a full physical examination. I would just lie him down on the couch. Well, okay, most of them will be lying on the couch if he's in the emergency department, okay? So you look at his hands, you want to feel his pulse, make sure he doesn't actually has a irregular rhythm, or, he doesn't have bradycardia or anything like that. And you want to look at his eyes, make sure he's not anemic. I would do the full physical, honestly. When you have delirium, you have to do the full physical. You check the heart, the lungs, the gastro, the CNS system as well, okay? Then additionally, of course, think about your delirium assessment methods. And at the same time, then you run some tests to help you come up with your diagnosis, okay? So there is no one specific test that you must do for delirium, because it could be any system that is wrong with you can make you confused. But with the history, it usually helps you to zoom into specific aspects lah. So he has muscle cramps in the legs. So yes, you actually will want to focus, definitely want to assess his lower limb neurological system itself lah. But you will also want to do a quick upper limb lah. Okay, good.
So, yeah, doctor, so I guess it's like, just to clarify, you do the full physical examination because you are trying to highlight or like look for specific causes of delirium, is it?
Yeah, like I've mentioned that any systems could be wrong and a patient can get delirium. So you need to do a full physical, there is no specific examination that you do for geriatrics. There is no one specific test in terms of physical examination that you do for delirium. So you're just going to have to do head to toe, but you may want to focus a little bit more into certain systems depending on where the history leads you. If it's really having a fever and he's coughing more, then obviously, you need to focus a bit more on the chest lah. But I would do the whole thing. There are many times I have had patients who comes in complaining of, lethargy, confused. And when you do a physical examination, they suddenly have a big mass in the abdomen. And the family may not even know about it. I have had a patient, a big mass, I put my hand, I was like, what is that? And I took the daughter's hand, I say, can you feel what is that? Is that normal for your dad? And they were shocked to find that. I have had patients who comes to my clinic with dementia. We've been seeing the patient for a long time for dementia, but a bit more confused. I just wanted to listen to the heart only, to be very honest. And I felt a lump in the breast, a big lump, and it's a metastatic cancer. So, you cannot say that, I'll just do this system, that system. I will just do neuro. No, you need to do the full physical. A quick one, and make sure you don't miss anything very obvious lah. Okay, coming to breast examination in an older person, make sure if they present with weight loss, confusion, or lethargic, make sure if they're women, you actually examine their breasts. And I can tell you, because most of the time, the older person may not tell you, and the family may not even know.
Okay, yeah, that's definitely an insight, doctor.
Yeah. No, honestly, because I had this patient really, when I listened to the heart, I felt the breast lump. And when I asked the daughter, do you know your mom has a breast lump? And you know what she told me? Oh, the daughter herself actually has had a mastectomy for breast CA 2 years ago.
Oh, gosh.
Yeah, so nobody actually knew that. I don't know, maybe it was passed down by the mom, or they may have some genetic predisposition to it. So you see, that's the importance of make sure you do the full physical.
Okay, I see, doctor. Okay, so as mentioned, so almost a full physical was done. So as from Mr. Ahmad's hydration status, it appears that he doesn't appear to be dehydrated. Respiratory, abdominal exams are all normal. So neurological, didn't appear to have any focal neurological deficits. Fundoscopy-wise, some findings for hypertension was definitely there. So apart from that, going on, what next would be, as mentioned by some of the people in the comments, or the cognitive test. So in regards to this, cognitive test, I think this is probably for some of us here, it's also new in regards to how exactly why do we do cognitive tests for like delirium, and like what is the significance of like cognitive tests in, for example, maybe diagnosing or helping to diagnose delirium per se?
Okay, just to clarify, in the physical examination of the previous patient, I have to say that I wouldn't have done a fundoscopy lah. Not that thorough yet. If they didn't actually present with very severe hypertension, or unless they really complain of some problem with the eye, then I would have done. But I haven't been so thorough that I do fundoscopy on every patient of mine who have cognitive impairment. But I have to tell you that I had a case where a patient comes in. The family brought her in because she had cognitive impairment. She has forgetfulness, and it's been having over the last 1 year. And they brought her to see me. And the only past medical history she has is that she's blind in one eye. She's blind in one eye because of glaucoma. So she's blind already. She's seen an ophthalmologist. And I did a CT scan of the brain and found out she has a large meningioma compressing on the optic nerve. And that was why she was blind in that eye. I did not expect to find that, but every time this patient gives you a history, like maybe a hint to something, like, or it may not actually, just to open up your mind. Like. So I was so surprised to find that. Eventually she had a meningioma resected. Then she said she wants to sue the ophthalmologist, but but that's besides the case. Okay, so I suppose it depends on the presentation. I may have done the same thing for her if I was the ophthalmologist, thinking that it's probably just glaucoma. So anyway, sorry to digress. Coming back to your next slide on cognitive assessment. Yeah. So why we do these tests that you've mentioned here? So all these tests has certain similarity. When people look at delirium, they actually identify many different impairment in different types of presentation for cognitive impairment. It could be behavioral change, it could be sleep-wake cycle reversal, it could be loss of attention, it could be disorganized thinking. So there are a lot, But ultimately, out of the a lot, they find that these 4 abnormalities are very, very specific to delirium. Hence, many of these tests that you've mentioned here actually looks at these 4 criteria. Besides your AMT4, AMT4 basically just ask patients 4 questions. What is your date of birth? Where are you now? How old are you? And what year is it now? So if any of it is wrong, it will trigger an alarm bell that you need to do a more thorough cognitive assessment. So that is a screening test. So all that you have mentioned here, 480 is a screening test, the CAM, Confusion Assessment Test, method should be, the CAM is also a screening test for you to do more detailed assessment and for you to link up your clinical assessment with your cognitive screening. Okay? So, because in a lot of times people are not quite sure, is this delirium? Is it not delirium? So like I say, if you think about these 4 criteria or 4 aspects that they have, then they are very likely to be delirious. So this one helps anybody, you don't need a psychiatrist to do the assessment. You don't need a geriatrician to do it. Any doctors who does, or even allied health who does the assessment would be able to tell if a patient has delirium or not. Hence, these tests should be something that is easy to do and easy to administer. Okay, maybe if you go to your next slide, then I can actually explain the test in a bit more detail. Okay, so this is the 480. So kudos to those who actually know what the 480 is. This is not to say very new, but it's been there for the last maybe 7-8 years. But in the last 2-3 years, it has been very popular. Lots of hospitals are using it. Lots of disciplines are using it. So they use it in geriatric wards. They use it in orthopedic wards. They use it in a lot of other different wards, which has older person to actually assess for delirium. So important thing is to know if the patient is alert or not. Any disruption in their alertness has high likelihood that the patient is delirious. Then you want to know how their thinking is. How do you check their thinking if you don't know how to check? Actually, when you talk to them, you should be able to tell whether their thoughts are disorganized or not. But if you really don't know what to say to them, and you're not quite sure how to test, then you ask them these questions. You ask them the 4 questions. Where are you? How old are you? What's your date of birth? And what year is it now? If any one of this is wrong, then alarm bells start to ring. Okay, so your alertness, your thinking, your attention. So if this person is drowsy all the time and you have to wake them up so that they can talk to you, then their alertness is not so good. So their alertness could be poor, or their alertness could be hyper alert. So that means they are very agitated, they cannot sit still, and they're looking here and there, they're easily distracted, they're all over the place. That is also a change in attention. So if that was the case, then it is likely the patient has delirium. Okay. And the last thing is this a change to their normal? So if you were to ask just one question, if the patient, like in this case, you just ask the daughter, is that normal for him? And the daughter said, no. Then you think this might be delirium. Okay, if you really cannot remember what else to ask, just ask, is this change normal for him? No. Then this could be delirium. Okay, so this 480 is just a way to help you to test and know what to ask and what to look for. So this alertness, disorganized thinking, attention, acute change and fluctuating cost is the same criteria that your CAM score is looking at. Okay, but you know, it is in a little bit more formatted in a way. It tells you what to ask, so you don't have to be thinking, okay, what to ask now. Your CAM, right, they just give you the criteria and you are supposed to identify whether the patient has these 4 things or not in your conversation. So if you take a good history, you should be able to tell. But if you really don't know, then you can use your 480 to help you assess lah. And it's very easy. We're teaching our staff nurses to use it, so anybody can use can do it lah, as long as you are trained, and training is very cepat saja. Okay, so if you put your next slide, I will tell you what we do in UMMC. Okay, so sorry, this is your 480 lah, because I thought that slide is a bit too small for you to see.
Okay. All right. Shall I just hop on to the next one then?
Yeah.
Okay.
Okay. So yeah. So attention wise, in the actual 480, right? It asks the patient to count your months, to name the months of the year backwards. So you do December, November, October, September, name it backwards. And you score according to how well they can name it backwards. But when we tried it in our Malaysian population, you know, not everybody knows how to name the months of the years backwards. So even when you ask them to do it, for maybe Malays, they will say bulan 12, bulan 11, bulan 10. So it's like counting the numbers backwards, you know. Or if you ask the Chinese auntie, they will say, oh, 12月, 11月, 12月, 9月, you know, they will be counting the months of the year backwards lah. So hence we decided that, you know, it's not so feasible lah. So we just change it to count 20 backwards to 1. Okay, so we've changed it slightly, and we have actually validated it that it is still valid, and it gives you similar scores lah. So that is why it is called My 480, Malaysia 480. Okay. So in the future, you should be seeing this in the EMR lah, you know, for some of you who are in the clinical setting in UM.
But doctor, as you mentioned, even though this is just a screening tool, right? It is not a diagnostic tool, right?
So the screening tool helps you in your diagnosis. So basically, you have to match it together with your assessment. And if the tool says that it is very possible delirium, then you could already say that the patient has delirium lah.
But because, like, as you mentioned, sorry, doctor.
Because I think the one thing to highlight about the 480 is that you can even use it in patients whom you cannot assess. So some of the doctors might say, hey, I cannot assess the patient because they are sleeping most of the time. It's very hard to arouse them. Or, you know, basically they are too unwell to be assessed. Actually, you can still. So like I say, it is always safer to think that they may have delirium than not to. So you may overestimate delirium, but it is better than you underestimate it. I mean the numbers lah.
Okay. Okay, doctor. Okay.
Oh dear,
so
it's gonna be 9 o'clock already. Haven't finished.
I think we should probably move on.
Move on.
Investigations, what needs to be considered. I think should we just hop straight to?
I think we can just continue. Just hop straight to it lah. So basically, it is like your physical examination. There is no one specific examination to do. So it's what you think from the history, the likeliest cause. So in this case, we would normally just do a full blood count and check the electrolytes as such. And if there was any abnormality from there, then we would continue to investigate further. Like because this gentleman has a thyroid disorder, I would do a thyroid function test. And if you find that over here, he seems to have hyponatremia, then you'll be thinking, oh, do I need to investigate the hyponatremia further? But in our algorithm, like I've mentioned to you in hyponatremia, if you think that it is a drug cause for the hyponatremia, then you don't have to specifically go and send off all your serum and your urine osmolality, urine sodium, you don't have to. But if it is not a drug cause and you're not quite sure what it is, then yes, you have to do all your other further tests to screen for causes of hyponatremia. Okay, you can move on.
Okay. Yes. So yeah, just very quickly the treatment principles. How do we manage delirium? I'm just gonna.
You manage it by treating the physical cause of the delirium lah. So that's the first thing. Sort out what may have caused the delirium. Is it a physical illness? Then sort out the physical illness. After you've done that, you need to make sure that your environment is also conducive for this patient to recover from the delirium. You will have it in your in your exams or something like that. If you ask you, oh, should we restrain a patient because the patient is very aggressive? The answer is what? Obviously, yeah, correct. We shall never say yes to restraint. Restraining someone is really very undignifying, because imagine if you are confused, people tie you to the bed, right? It's really bad lah, okay? So I'm just trying to tell you that there are many ways you can nurse a patient. So the one on the picture on your left is in Singapore. This is in Changi Hospital. So they've got a new unit, it's spacious, the workplace is in one setting and the patient's beds are in one setting. But if the ward is very crowded, then the patients can get more and more confused, they are your roommates who are shouting, screaming, the other one, a lot of machine beeping. I think if I am in that condition, I would be delirious as well. So this is to minimize and to enhance the recovery of the delirium. The environmental factor is also as important. Okay?
Okay. Yeah.
Again, this is just to highlight the importance of your environment factors lah. So a lot of people, after they stay in the hospital for a long time, they don't even know is it day or night. They don't even know what date, what month is it. So it's good to reorientate them lah.
Okay. And yeah, I guess this is a pretty important slide as well. I remember you mentioning it to us when you taught us, doctor, regarding.
Correct. So it's just to tell you that if you have got anyone who has delirium, think, do they actually have cognitive impairment? Because when you have cognitive impairment, it reduces your threshold for getting delirium. So always ask about what were they like before. Okay?
Okay. So yeah, doctor, should we just save the Q&A to the end, I think, right?
Yes, can. Because I'm not quite sure if we got any question, but you can continue to type your question out, then we will answer that towards the end lah.
Okay. Yes.
All right.
Let's go.
All right. So I guess we shall move on to the second case. Yeah. Let me just press control for the slides. Yeah. Okay. So for the second case, the patient is Madam Lim. So the prompt is that she's a 76-year-old lady referred to you in the memory clinic for assessment of memory impairment. She attends in the company of her 2 daughters, and she acknowledges that there have been memory problems, but feels it's just her short-term memory that's an issue. Yeah. So Dr. Khor, for this kind of patient, when they are referred from referred to a memory clinic from a GP or somewhere, so what would normally be done to this patient? What are the first things that are going to be done?
Yeah. So this patient was actually referred to me by a neurosurgeon, because I think they went to see a neurosurgeon first, and the neurosurgeon scanned the brain and said, well, there's nothing wrong with your brain that I need to fix, so you go and see a geriatrician. So that's why she came to see me lah. So like in any case, try and assess what may be the problem with her memory and whether other aspects of her cognitive function has changed or not. Okay, so that's very important lah. So that would be usually what I would do first. Get a history lah. Why do you think her memory is poor? What do you mean that her memory is poor? Give me some examples. I always ask them, give me some examples. What has changed? Was she not like that last year? Last Chinese New Year, she's not like that. So you also want to identify how quick was the change. Anyone with confusion, like what you saw just now, how long has it been going on? Did it appear or did it occur just very suddenly? Is it an acute change? Yeah.
Okay. All right. Yeah. So I guess we can move on to the simple history that we have.
Yep. I have many relatives who come to see me, and you know, basically I ask them a lot of questions. I'll ask them, what medical problems do you have? Who sees her for this and that? How is it controlled and this and that? Then after that, they'll tell me, oh, those ones, oh, okay lah. The cardiologist is seeing the what and what is seeing lah. We only want to know what is the problem with her memory. But you cannot, because memory impairment may be because there's something physically wrong, or actually something wrong with your neurological system itself. So it's very important to get the full history lah.
Okay. Actually, I can't seem to move the slides in.
Oh.
Can you? Yeah. Or do I have? Okay. All right. So the presenting complaint history. So she owns a gift shop and is very active in many different associations and activities. But then she stopped handling finances and left it to her staff. But she also cannot recall recent conversations, and she would rather stay at home than to go out with friends. And the doctors thought that she might have depression, that she might be depressed. And then she is also unsteady on her feet, and doctors need to keep her company and need to help setting up for meals. And she will occasionally clench her right fist. Yeah. So, doctor, looking at this history, which history would you think is a bit more significant than would point to certain diagnoses?
Well, I think the history tells us that, you know, what was she like, and there had been a change. And when you get the history, sometimes the doctors might tell you something that you don't expect to actually find. So when they say clench her right fist, what do you mean by that? So usually they'll show you lah, you know, they'll show you. I want to ask her, show me what does it mean and what is it like, you know. So you want to know, and normally if they can't tell you, or they feel it's something abnormal but they can't explain it very clearly, and you don't really know what it is, what they mean. So I would say, if it happens again, can you take a video? Because now with video, with your smartphones, right, it's so easy to capture anything with a video. So that's what I would tell them to do lah. Because I have to say, this is a real case referred to me by a neurosurgeon. I had no idea what she meant by that, and basically I said, if it happens again, can you take a photo? And I examined her, I don't feel anything abnormal. So it's been left at a side lah. Okay.
All right.
Yeah.
So what about
Sorry, go on. Kenneth, go on.
No, I just wanted to ask, what about the unsteadiness of her feet? Like, because from the history we know that there seems to be a little bit of like memory problem. Yeah, but what about the unsteady of her feet? Like, would we look into that as well?
Yeah. So so you will want to know, unsteady on her feet, you know, has she had any falls? Has this happened before? So to me, I'll be thinking, oh, could it be a medication problem? But she doesn't seem to have any new medication started. So in your examination, you want to watch her walk lah, and to see, you know, what may be the cause of this. So you get one whole lump of all these symptoms, and you're trying to piece them together. So at the moment, I also don't know what may be the cause of that.
Okay. All right.
Sorry to interrupt, but I guess would like something with Parkinson's or Parkinsonism related causes of dementia be something to consider in this case, doctor?
Yeah. So you want to know that, you know, how long have you noticed that? And let's say if you think that it may be Parkinson's, so normally, I mean, unfortunately, because you don't have the patient with you, you know, when you are doing case-based like this. But when you look at the patient, you just want to know, oh, okay, has she got any Parkinson-like features? Then you want to also ask the doctors, oh, you know, has she been doing things more slower? So you may want to consider, could this be a Parkinson-related dementia or Parkinson-like dementia? So in your physical assessment, you want to particularly look for it. I agree, you would want to do that.
Okay. So, doctor, like in terms of the history-wise, is there anything that we would need to ask further, or any extra?
What do you think?
Yeah, actually, I mean, like when I go through the case, I think we can all agree that there's some memory, some form of dementia, but maybe like in the history, you would want to find out the cause of the dementia, maybe like some of the reversible causes of memory loss, like the hypothyroidism, like let's say infections and things like that.
Yep. Yeah. So one thing we need to know is also the timing. Like, how acute did this happen? Like I've mentioned, is it very sudden? Is it in the last few months? Or is it a gradual progression over the last 1 year? Because your diagnosis differ according to the speed of how quick this change has happened. So it does not tell us in the history exactly how long this has happened. But I think what the daughter would say is that, during Chinese New Year, well, we're talking about last year, during Chinese New Year, she was still okay, talking to the relatives, inviting them in and no problem. But, a month later, she's changed into situations like that. They can't exactly, well, they sort of but they can't exactly pinpoint it is this date or that date, but they say that gradually over that 1 month, she has changed. So in a way, you'll be thinking, gradually over the last 1 month, can it be dementia? As in can it be Alzheimer's that has changed so quickly? Unlikely, isn't it? So yes, I agree. You'll be thinking, can this be an infectious cause? But she doesn't have any signs of, having infection. She doesn't have signs of meningitis or anything like that. And she looks quite well when she's in front of you. So how?
So yeah, in this case, like we also I think we mentioned just now also like in terms of like some brain neurological problems, we might need to do a CT brain like later on, or we can check the medication, see if there's any changes. Is it
Yep, I would do that.
Okay. So is there any other things that we need to ask like further in terms of like finding out the causes?
Yeah, I think in the presenting complaint, if we know that the change has been quite sudden, so like what you've said you want to know, what are the causes that can suddenly cause your cognitive function to decline? If you say it's delirium, it's been more than a month or two already, and you want to do all your tests to find out if there's any physical causes for it. But the other thing you'd be thinking is, could this be a vascular problem that has come on quite suddenly and persisted until now? So those are the things that you may want to consider. It's in a way quite rapid in terms of the change in what she could do now, what she could do before, and what she could do now.
Okay.
Sorry, doctor, to interrupt. Are you when you mention vascular problems, are you referring to vascular dementia?
Well, that was exactly what that was exactly what I thought, I have to say that I was, in my mind, I was like, this might be that, don't know the number what dementia that I've seen. You'll be thinking, is this a vascular dementia that I'm looking at? She's got an age, she's also got the risk factors. This could very likely be vascular dementia. Okay. And you've only done a CT brain. The CT brain did not show any major stroke that has happened, but you'll be thinking, okay, maybe if I do an MRI, I'll see lots of small vessel ischemic changes. We usually grade it, we might say it's fuzzy class 3 or 4. That means there's extensive white matter changes. That could also be a multifocal infarct kind of dementia, which is along the vascular aspect to it.
Yeah, I understand. Sorry, Kenneth. I just want to ask a question to clarify. In the sense that, so my understanding of vascular dementia is that these patients suffer from micro-infarctions in the brain, and like they have a stepwise deterioration in regard to their cognitive function. But does this mean that patients with vascular dementia, like they are suffering from multiple strokes? So every time, besides their cognitive function going down, it's also their motor function goes down. Like, is that the case, doctor?
Yeah, there are also many different types of vascular dementia. So some of it may be you have a strategic infarct, and that has then caused that acute change in your motor function. So you've got people who have partial anterior circulation infarct. They have weakness on the whole side of the body. You will also note that their cognitive function have declined with the same time as they had the weakness. So that is the large infarct sort of vascular dementia. You have some patients who never really got admitted to hospital for a stroke per se. They never had very obvious weakness per se. So, but those you may have what we call multifocal infarct type of vascular dementia. So they have got lots of these little infarcts. And as they change, you know, if you have one more new little infarct, you may not see a big difference on the scan, but their cognitive function has declined. So like you've mentioned now, you know, you may have another more tiny stroke and you still get that stepwise decline as well. So there are many different types of vascular dementia. Some, like I say, is the very obvious strategic infarct accompanied by the motor weakness. There are some who does not have any significant motor weakness, but they have little small infarcts, multifocal infarct. But in those patients, although you do not have obvious motor dysfunction, they tend to have psychomotor retardation. So that means everything is a bit slower. You talk to them, it takes them slower to answer. You ask them to get up from a chair to go to the dining, it takes them slower. So the slowness is there. And these patients may also present in what looks like a Parkinsonian gait. So you'll be thinking, is this Parkinson's disease? But that's what we call vascular Parkinsonism. So mostly affect the lower half of the body. So the walking like a bit shuffling, but you test their arm, there's no cartwheel rigidity or anything as such one. So, but very slow in their movement, a bit shuffling. So, and if you do their brain scan, you see lots of infarcts at the same time, a lot of small vessel ischemic changes. So that's what, there are many types as I've mentioned.
Okay, yeah, thank you, doctor.
No problem. But I have to say, during that time, I have no idea what this clenching of her fist is. Okay, if you go to your next slide, what's that?
Yeah, the next slide is just, I think, on asking whether there's trauma or any mental health problems. I think probably is to rule out the other, like whether the patient has depression and so any trauma.
Yep. So I was trying my very best to find out what may be the cause. You know, there was no such thing as it is. Okay?
All right, okay.
Yeah.
So for the past medical history, the patient has type 2 diabetes for 10 years and then hypertension for 20 years and is well controlled with medication. Yes, and then there's also GERD for the last 6 months and no previous surgeries and allergies. Okay, so for this doctor, is there any a significant past medical, part of the past medical history?
Yeah, when I saw this, right, I was quite happy because it also coincides with my suspicion. I was thinking this is a vascular thing, you know, I'm putting my money on it already. So nothing to change. But you know, when you ask, has there been any change? What is the control like? You know, you want to know what is their blood pressure control like. You want to know what a diabetes control like. It's just like how you would take any normal history. So in this kind of cases, I would also want to do an ECG. So they say, my blood pressure is very good, very well controlled. But if you do their ECG and you see that lots of, you know, left ventricular heart strain, you'll be thinking, really? Is it really so well controlled? Then you have that suspicion. Yeah, so ECG is also very important.
Okay, okay. Yeah, so I think we can move on to the next slide. Yeah. Okay, for the other social histories, I think she never smoked and never drink alcohol, and then currently lives alone in a multi-storied house, an active lifestyle, and does morning walk. So she's still independent in all her activities of daily living.
I think this is what she used to be before. So a lot of the social history aspect we've already mentioned during the presenting complaint, because when there was a memory change, you want to know what she can do, what she can't do. So previously she was really independent, but you know, that is quite a quick change in her function as well.
All right, okay. So like, doctor, for this type of dementia, is there any because we know that there are a few types of dementia, so like according to the time itself, like can we differentiate each of the dementia by looking at how acute it is?
You can. So if something that has happened more chronically, you'll be thinking like your usual neurodegenerative type of dementia. So that is the usual type which we taught you, like your Alzheimer's disease, your frontal temporal dementia. Vascular dementia, a little bit, you have that stepwise pattern. Okay, and other things are like Parkinson's disease dementia, Lewy body dementia, you know, cortical basal degeneration disease. So you think about those things. But if it's something that's happened so rapidly and a change from someone who actually going out doing things to someone who now becomes more supervised, that is not normal. So then you were thinking about more of a possible other diseases. Could it be infection? Could it be a prion disease? Could it be an autoimmune encephalitic problem? So those may then start to raise your suspicion to other aspects of dementia rather than the usual mundane neurodegenerative diseases that, you know, it's much more common now. So I'm talking about those are really very common. And most of the time, it may be those neurodegenerative changes, but there are also other aspects in different ways the patient present makes you think about other causes lah.
Okay. Yeah. So in this case, the progression and so is really important
Yeah.
Okay. Yeah. Okay. I think you can move on. Ian, you can move on to the next slide. Okay. So the key features of history for dementia, and so these are some of the questions I think we would like doctor to help answer, I guess. So what are the important parts of history do students commonly miss? And also what are the challenges taking history from dementia patients, as well as like any unique history or any approach that we should use? Yeah.
Well, I think understanding about how do you take a history of someone who is confused, who have a change in their cognitive status is important. So it's really like I've mentioned, basically getting to know what is their normal. If you really don't know how to start, where to start, then you just go, what do they do at home? Let's say from the time they wake up, what do they normally do? Then you know how this person lead their day-to-day life. And if you say that this was what they do last time, they can do this wake up, do that, then after they go that, then they do this, they have friends and they go out. And now they're actually just housebound and they need help to do all this. You know that there is a change. Because I don't hope that students will not be, don't know what to ask for. It's not chest pain or it's not short of breath or it's not diarrhea or, you know, you don't want that, you know, but it's really about having a conversation, you know, with the person itself. And knowing also from your knowledge about cognitive function, you can zoom into those aspects to ask okay. And in this, very important, because if you think that could this be delirium then make sure you know, is this an acute change? You know, when did it happen? And you know, does she have disorganized thinking and stuff
Okay. Yeah. So like any tips that you would like to give to us, or any challenges that we would be facing when we talk to patients with dementia? Like maybe they don't answer us that fast, or maybe we don't know whether they understand our questions or not, like things like that.
Yeah. If you talk to them and you feel that you are not able to have a normal conversation with them as you would have with your own parents, something is wrong. Okay, so don't think that old people, they talk like that one. No, okay, always not think of older person who are different. You know, if you can't have a normal conversation to them like how you would have with your parents, then something is wrong okay. So yeah, so I think that's important to note that, you know, if a person is confused, it's not normal.
Okay, all right. So I think we can move on to the next slide. I think it's on investigation. I think they mentioned that there's a dementia screen that was done prior to the referral. Yeah, so we would like to see what was the dementia screen about.
Do we want to open this to the
to the student?
Yes.
I think that's a question, is it?
Yes. Hey Yi wants to know how to insert an IV line in a delirious patient. Well, the question we need to ask ourselves is, need to insert or not? Don't insert, can or not? So if really cannot not to insert, then you will have to get help. And it depends also the severity of the delirious patient. If they are quite calm, but they will move their hand a bit or they're scared, you want to really look them in the eye, be nice, smile, say yes, thank you, please. So usually that puts them at ease. And you must ask them, you hold their hand and say, I'm going to try and put a line here. They may not understand, you know, but gesture shows a lot. So if your if you are not very intimidating, you get to their eye level and you slowly ask them and ask the nurse to hold, reassure them, tell them every step what you're going to do. You would roughly know whether this is going to be a very difficult IV insertion, you know, this person is going to pull their hand, or you think that actually not so bad, like this patient is not so confused. It's by telling them one step at a time. I normally will tell them, I'm going to put a line here. I show them the branular, put here, and see what their response is lah. Then after that, I will tie the tourniquet or put the tourniquet on and see what their response is. But you must tell them, I'm going to put this over your arm, a bit tight, okay? See how it feels. If you do that, put the tourniquet, they are already moving their arm, you know, hitting you, then you know lah, inserting the eye line is going to be very difficult lah. Then you either have to actually get help to help you, or don't insert the line, give them tablet to take. You know, think of other ways lah. They may also be that you insert the line, they keep pulling out. So what do you do? So what some of my friends do is that sometimes it's just about things attached to them they don't like. So sometimes they put a fake granula, as in like not attached lah, you know, they just plaster it. So they try to remove that rather than the real granula lah, you know, just certain tips lah, you know. Okay. Yeah, sorry. Okay, go on. But no one wants to write what kind of dementia screen they want to do.
Yeah, anyone wants to say, like what investigations would be included in the dementia screen? Yeah, and also if anyone still want to ask like for any tips from Dr. Khor, so you can add in the chat. Yeah, so we can. Yeah, so I guess.
So maybe we can just quickly show them what the dementia screen is. So basically, it's similar to a delirium screening test lah. So I would usually do all this anyway in someone who may have confusion. So I would do that. And a CT head for dementia, I will, because I've actually showed you some examples of changes in the brain scan, which also surprised me. But like again, this also depends on how cooperative the patient is. If the patient is someone who will not want to do a scan, and you feel that okay, this is very likely to be possible dementia rather than anything else, then don't need to do a scan. Because if they're so resistant in doing it, it is very likely that if you find something very, very sinister, they're going to want to do anything about it lah. So discuss with the family, make a decision of whether you want to do a scan or not. But ideally, gold standard, you should. I would say that if you can, an MRI rather than a CT scan. Okay?
Okay. Yeah. Okay, doctor, so anything, so that's all for this dementia screen, is it? Like, I think LFT, TSH, B12 folate, CT head, yeah, it's just now doctor mentioned also, yeah.
Okay. Initial screening, if those screens shows anything abnormal, then you go towards that aspect of it lah.
All right, yeah, okay, so I think you can move on first.
Yes, we have someone in the
testing. Yeah. Sorry?
Oh no, we have a new answer. Mocha testing.
Okay.
Yeah. So that's so what we see here. This is the blood test. Then how do you test for dementia? Yes, you want to do cognitive testing lah. So the easiest is MMSE. MMSE, your mini mental state examination. The reason is just because everyone in the world uses it lah. And if you can go on to your next few slide, I think there is a MMSE stuff. Okay.
I think your next slide, yeah.
Okay.
I think there's a picture, sorry.
Yeah. So so that's your mini mental state examination on your left. So it actually tests a few domains of your cognitive function, and your MOCA is on your right. So this one is a bit harder. So if you've got someone whom you think that they are fairly highly educated, probably better to use the MOCA because it is more sensitive in people who have higher education. But it all depends. If you've got someone who has higher education, but when you're talking to them, they are already confused, then don't bother doing the MOCA lah, because they are very likely to not score well on it. So you want to just do the MMSE. But if you find that, I'm not quite sure, in the history sounds as though there may be something not quite right, but they are still trying to cover up, then you do your MOCA lah. Okay? Because MOCA will be more sensitive.
Yeah. Okay. Oh, doctor, there's also another question from Su Ying. So she asks, good evening, Dr. Khor. Can I have you to briefly explain what is vascular dementia with BPSD and how would you come up with this diagnosis?
Yeah. So BPSD basically is behavioral and psychological symptoms of dementia. So whatever dementia you have, you can also get BPSD. So you can have Alzheimer's disease with BPSD, you can have Parkinson's disease dementia with BPSD. So BPSD just basically means that this person has a behavioral symptom from the dementia. So BPSD can mean agitation, irritability, apathy. Apathy means no motivation. They just sit down and don't want to do anything. Okay. They can have hallucination, paranoia, wandering. They can have sexual disinhibition. So all these are the behavioral and psychological symptoms of dementia. It does not mean that if you have vascular dementia, you have this group of BPSD. If you've got Alzheimer's disease, you have got this group of BPSD. No. You can have any type of dementia, and you can also have any type of BPSD. Okay? So it just tells you that besides cognitive impairment, this person also has a behavioral problem or behavioral issue. The reason why we focus on a lot about BPSD is because that is the most difficult symptom or issue for family caregiver. Okay, if your grandmother or any of your loved one are just pleasantly confused, sit there, smile, you give them food, they eat, they go toilet, you ask them, who am I don't know, I cannot remember, you probably feel that it's fine lah, it doesn't cause so much anxiety to yourself or to the caregivers. But if they start having a lot of behavioral problem, then that causes a lot of issues lah. Yeah. So basically, this just means that the dementia has a huge behavioral component to the symptoms and the presentation. Yeah.
All right. Okay.
Okay. Maybe I just clarify a bit lah. So they are, sorry, contradicting myself. They are specifically, if you talk about Lewy body dementia, then yes, in terms of the BPSD, a lot of them have hallucination but the rest, right, they're no specifically saying that this one got more of this type of BPSD or that type lah. Okay.
Yeah. All right. So we also look into another aspect, which is the behavioral part.
Yeah.
Okay. All right. And then I think there's another question. There's another question from Khor Ying. How to differentiate if the patient has depression on top of mild dementia, or if the dementia has worsened?
Yeah. Okay. So basically, that is true. Depression, dementia, very closely knit together, and then delirium also. So it's very hard to piece them out. So you really want to focus on what started first. What started first, and because most of the time they come in with like cognitive impairment, but then anxiety, cannot sleep. So you want to ask the family what started first. Because sometimes they may be depressed because they are forgetting things. They are frustrated about why I'm forgetting and I'm not getting sense of, doing this, why I'm not able to do what I used to do before. They might feel that they're useless. They might get depressed because of their cognitive impairment. Okay, if that was the case, you treat the cognitive impairment. You may have to treat the mood, but you hope that you manage the cognitive impairment, the mood may get better. There are patients who have predominantly a mood problem. History of previous midlife depression, very complicated social environment. And the depression is huge to a point that, they may even get paranoia or hallucination, seeing things. I've actually recently had a patient like that also. But then when you do their cognitive assessment, they're not so bad, they can actually reason with you as well. But hugely, it is a mood problem. Then you want to treat the mood first, okay? So these things you have to try and piece it out, but it may not be so easy. And many patients, I have to end up treating both the depression and the dementia. Like I've just had a patient I saw in clinic a couple of hours ago because we had the memory clinic. So her initial presentation, anxious feeling useless, that she cannot do what she used to do before. MMSE is 22, not normal, but huge amount of mood symptom. She's ADL independent in the house. doesn't have any friends, doesn't want to go out, worry about, saying the wrong things if she forget things and make a fool of herself. So that was a huge mood problem. We started her on SSRI, so we treated the depression first. Ultimately, the mood problem actually improved. She is stable. I mean, she's not like very, very happy lah, but she's at least stable and not too low in mood. Her appetite is okay. She's sleeping well. But 1.5 years later, her MMSC is now 14. So what I did today, I started her on medicine for the dementia. So they may continue, they may have this interlink, which actually has been shown also that there's a close link between the two. But initially, you want to piece it up first lah.
Yeah, so we really need to know which one comes first lah, to know which one is the main one that we should treat. Yeah. Okay, so there's also another question. How do you assess patients' long-term, intermediate, and short-term memory? What question do you usually ask to assess this?
Yeah, there is actually what we call CDR, clinical dementia rating. Okay, I used to have to do 7 hours of this online course to learn how to do the CDR, clinical dementia rating. So basically, you are looking about different aspects of the memory test. So things that we ask whether they have short-term memory problem or not. Okay, short-term memory problem, the questions that we ask usually in the history taking, you will ask the family members what are the things that they forgot? Oh, they put things somewhere, they cannot remember where they put. They eat already, they cannot remember. They keep asking the same question over and over again. They keep asking me what time is the doctor come? What time am I going to see the doctor? So that is short-term memory. Okay, long-term memory are things that happened long time ago. So information about previous past So that's to test for your long-term memory. So in the CDR, clinical dementia rating, the assessment that we do is we actually ask them, what school did you go to? I mean, what school did you graduate from? That means your secondary school, okay? What did you retire as? What year did you retire? How old were you when you retire? Okay, so those are the certain things that we ask them about the long-term memory. And usually in the assessment is that, we give them a list of words to remember. And after that, we ask them again, what was the list of words that we asked you to remember? That's to test for their short-term memory. Okay, so the assessment is like that. But, like I say, in your history taking, usually you'll be able to identify. The family most of the time will tell you, things that happened just now cannot remember. The friend that came and talked to her, the information just now cannot remember. But, long time ago, who owned them money, who and who had this gossip, they can remember. So that will give you a hint that the person has more in terms of the long-term memory compared to the current short-term memory loss that they have.
All right. Okay. Yeah. So I think that's also another important part of the memory assessment as well for memory. Okay. So Raymond also asked a question. Good evening, Dr. Khor. Since you mentioned earlier that restraining a delirious geriatric patient is not appropriate, what's the best approach to dealing with such patient who is behaving aggressively and may pose a danger to themselves?
Excellent. So Raymond is, asking all the question appropriate as the houseman or the MO always ask me, because we say cannot restrain. They were like, Dr. Khor, then you say how? The patient is so aggressive, this and that. Don't restrain, then how? Okay. Restraint are many methods. They can be physical restraint, tying them up, okay? Or they can be chemical restraint, giving them medicine to calm them down. Yes, if a patient is actually aggressive to themselves or causing a harm to themselves or to other people, yes, then you need to, number one, you find out why, and then try and solve the problem. If it is not a very apparent problem, then, you have to do something immediately, then you have to restrain. Normally, I would then choose to use chemical restraint because physical restraint has also got its own issue. They are trying to get out of the bed and you're tying them up. What will happen? They'll cut themselves. I rather give them a dose of haloperidol just to calm them down so they don't hurt themselves so much like that. Okay, so yes, I do have to restrain patients, but not using physical restraint. We try and minimize that as much as we can. And I will only restrain, whether it's chemical or physical, if only, like what you've mentioned, it is a harm to the people looking after them or to themselves. Many times, the restraint that I've asked that they ask me whether can restrain or not is usually patients trying to get out of bed, want to go toilet. I told them cannot go. Then bring them to toilet lah, it's another thing is like patient shouting a lot. Shouting, if it's not disrupting them, then it's not so much of a bad thing lah. Then find out why they're shouting lah. Is it because they're scared? Is it because they're in pain? Is it because they're hungry? You know, why? So find out why they are behaving like that, sort that problem out, rather than every time got problem, restrain. Patient cannot sleep talking to herself, you know. If she's not distressed talking to herself, then never mind lah. But I understand some patients might be very distressed when they have delirium, especially acute delirium, and the usual things that they may get is visual hallucination. That literally, usually it is animals or children. They will see spiders, or you know, animals that is very horrifying. Then they get very scared, they get very agitated. You know, they're very paranoid. And then yes, I would normally give them something to calm them down. Or they might see children with no face and this and that. So those are usually the things that they see okay. Yeah. But some is like, you know, very pleasantly confused, but not causing any harm to themselves or other people. I don't restrain.
Okay. All right. So, doctor, there's also another. There's also another question from Christine. She wanted to ask whether
still about inserting the branula, is it?
Yeah, inserting the branula. How can we distract them? I think.
Okay. Yeah. So I think another person will help. Let's say if they are yes, if you distract them, or the other person, usually the other person will hold the other arm and say to her, talk to her, and you know, try and distract her from what is happening on this arm lah. Okay, if she's allowing you and she's not resisting it fully, yes lah, that poke might be very scary and very painful for that short while, but usually after that they settle and you say, okay, done already. They're like, okay, fine, yeah. So I had to actually physically console or distract an elderly woman who was just going for ultrasound. So they called me to say, Dr. Khor, you see, you want ultrasound, this patient we cannot do. So I said, you know, purposely come for ultrasound, cannot do. I say, why? Very aggressive. So I have to go down. I have to put my arms on her and say, auntie, you know, look at me, talk to me. Because ultrasound also not painful, what? But you know, she was aggressive because of it lah. So those are the things that you can do lah, console them and tell them one step at a time what you're going to do, what they need to expect. So it helps. Yeah.
All right. Okay. Yeah, thanks for answering all the questions. Yeah, I think yeah, for the question, I think it also needs a lot of experience, like how Dr. Khor manages. Yeah. Okay, doctor. So for coming back to the MMSC and MOCA, so is there any other aspects inside the test that you would like to especially mention or something?
I give you one trick, especially on the MOCA. You know, you see that trail making test. You see the bit, I would tell people, the first test where it says visual, spatial, stroke executive. You see the circles, in the circles, they are letters and they are numbers. So what you're supposed to do is connect one number to a letter and a subsequent number to another letter. And, you know, until you end at, I usually point to them, you end here. Okay, so you try and use one line only, connect one letter, one number to a letter and subsequently. So I will tell them so there's an example, 1 go to A go to 2 go to where, so that you're supposed to do it. If in this test, they're already kelam kabut, it is very likely there is some cognitive impairment. The rest of the test is also going to be tough problem lah. So that's a very sensitive test to actually look at the person's executive function and also their visual spatial. So if you got no time, you just do the trail making or problem, it is very likely there is going to be problem elsewhere. Specifically on this MOCA. Yeah, we find it very sensitive, the trail making. Not to say that if they score the trail making normal, the rest also is going to be normal. No, but trail making is quite sensitive. Okay. So I think I better let you just to sum up the case that we have talked about, this lady who is acutely confused. So what happened was that I put my money in vascular dementia because it's the common thing I normally see, vascular dementia, you know. But actually what happened was that the CT brain does not show massive amount of ischemic changes of multifocal infarct. And subsequently, I wanted to do an MRI, but she was too anxious, cannot do the MRI. So she has to do under sedation. I said, you come back another day and do it under sedation. She came back 2-3 weeks later. She was totally different. her cognitive function has declined even further. Now she was hardly able to walk well. And the daughter is telling me that, you know, when she eat, she seemed to overreach the spoon, like cannot find where the spoon is and this and that. So that's not normal. The clenching of the fist also happens. Sometimes clench so hard, she cannot quite release it. But when you examine that time, nothing, you know. Ultimately, what happened? She fitted in front of me in the ward. And you wonder, oh no, this is not right, you know. Rapid decline in cognitive function, seizure as well. You have to think about all the causes of rapidly declining dementia, okay, rapidly progressive dementia. So ultimately what we did was that, of course, we did an EEG, we did an MRI, we even did a lumbar puncture. So specifically in this age group and this change and this jerk and this seizure, which is suspicious of CJD. So we did a lumbar puncture to send for protein 1433. Okay, but you can understand to look for this test, I have to send it to America. And unfortunately, when things go wrong, things will go wrong. So what happens is that the lab was closed. So it's not going to be reopened for don't know how long. So they resend the sample back to us. Then we have to send it to Australia. But at that time, I have to say the patient deteriorated so quickly. She was intubated, ventilated because she has an infection. Like I say, rapidly declining dementia, delirium, infection. She got even worse. So we had to intubate her just because she had a UTI. She got a urosepsis. Okay. Once intubated, cognitive function has already declined. We couldn't wean her off. She had to have a tracheostomy. So the MRI was suspicious for CJD. The EEG was suspicious for CJD. You need 2 out of the 3. MRI, EEG, and also the protein, the CSF. So we didn't get this one. Family said, forget it lah. We're not going to pay any more money and send it to Australia. We accept, you know. So she was actually, in a way that her quality of life has declined. She's totally dependent. She's in a nursing home, and we suspect if in CJD, their life expectancy is also going to be poor lah. Yeah. So remember, you know, things that you see all the time may not always be the same thing. So in rapidly progressive dementia, you know, you've got all these things, rule out infection, rule out autoimmune, because, you know, you may never know they've got autoimmune encephalitis. That is a little bit better in terms of treatment. You know, you can give them high-dose steroid and hopefully that will improve a little bit. It could be malignancy, so we have to send off all these paraneoplastic tests. It could be vascular, which what I thought it is because it's so common, okay? Or it could be actually a metabolic cause lah. So think about it lah. Okay, so I thought giving you a case of something not so common and something more common just to let you know how fast the progression is very important. Okay. All right.
Yeah. Okay. I think that's a very interesting part that we about dementia. So like it's not that straightforward as well sometimes. Yeah. Yeah.
Yep.
Okay. All right. Then we can move on to the next. Is there any questions?
Oh no, because Doctor, you mentioned even vascular. When you say rule out vascular, so I'm assuming it's not vascular dementia you're mentioning about, is it?
Yes. I'm talking about a vascular cause of the dementia. Cause could it be like she's got lots of multifocal infarct, you know, that she's declined? A lot of people also may get what we call frontal infarct. So when you do the CT brain, memang got a hypodensity area, memang got acute infarct, but there's no weakness, but they have an acute change in their behavior, in their executive function. Suddenly, they don't know how to do certain things that they're always good in doing, because that's what your frontal lobe helps you with. So many times you have seen people with a frontal stroke, but no presentation of a clinical motor weakness per se. So I was putting my money on that, but you know, the CT brain didn't show it lah. The CT brain didn't show it. I thought maybe, okay lah, maybe multifocal, infarct everywhere and very bad, small vessel ischemic change, but don't have also.
But doctor, but even for those like vascular dementia, you consider it rapidly progressive?
The acute change, yes, it can be. Yeah. So I guess if there is no motor weakness, right, usually you don't find it so acute. I mean, acute change, yes. But in this case, acute change and progressively deteriorating, unlikely to be just vascular. So if acute change, she stopped there, I would think, okay lah, maybe it's vascular. But the problem is she didn't stop there, but she declined and declined and declined. So that's not normal for vascular dementia to cause that.
Mm. Okay.
So I had a patient also quite quick decline, but her MRI showed huge amount of small vessel disease ischemic change, and he also has cerebral amyloid angiopathy, CAA, which in a way is to do with the untreated hypertension for a long, long time. And these kind of patients may either have a massive stroke or they may even have a bleed because CAA is associated with hemorrhage as well. Yeah, so that one can explain now, you know, but he actually declined, but stop there. But this patient declined and declined and declined and declined in very short time period.
Mm. And doctor, you mentioned that you saw something that is characteristic of Cruciate Jacob on the MRI, is it?
Yeah, that one also I belajar lah from my neurologist colleague. Yeah. So if you look at the literature, there are specific changes lah. So in hers, she has what we call ribboning-like changes like in the cortex. So when in the MRI, right, you could see that the cortex area, you know, has a bright lining around it. Yeah, I have to say these changes, even for neurologists, it has to be you are thinking about it, looking for it, then you can find it. The first time when we did the MRI, the report says no major change, you know, some ischemic changes here and there, but nothing massive. And I spoke to the neurologist, I said, hey, macam mana MRI ni? So they then took it to a neuroradiologist to look at it, and they said, oh, actually got ribbon-like changes, and they changed the report. So these are things that, you know, you have to look for it, and you have to have, because it's very rare, you know, you have to have the specific expertise to locate it .
Okay. Thank you, doctor.
Okay, no problem. Okay, any other questions? I thought this was going to be an hour. Sorry, Dr. Mark.
Yeah, I think we are almost approaching. So, doctor, so for like dementia, how is it managed? Like, how the treatment principles for dementia?
That will be another hour, you know, Kenneth.
Yeah, I know, because as you see that there's so many different types of dementia, and I think there is also a different management for all of them. Yeah.
Well, actually, basically what you want to do is to diagnose, educate, and to slow down the symptom manifestation. There is nothing that you can do to stop the disease process. The disease process will continue, but you want to slow down or slow down the manifestation of the symptom. At least the family member can manage lah, okay? And manage all the other medical issue. Because like I say, if the medical issue decline, they also decline at the same time. Yeah, so that's generally how you want to manage it .
All right. Then we move on to the last part which is just some discussion. Yeah, can we move on to the next slide also? On the differentials of confusion. Yeah. I think this was a slide. Yeah. No. Ian.
Oh. Yeah. Kenneth, you say something?
No, I thought this was the slide for the first case, I guess, for the confusion.
Oh, okay. Sorry. Before we go on, we have a new question by Zhen Yu. So how is sleep cycle disrupted in vascular dementia? Will it be more towards sundowning syndrome or sleep cycle reversal?
Okay. So whether is this just as to explain what the sundowning syndrome or sleep-wake recycle mean. So sundowning basically is a term used to illustrate that when during the evening period or the later on during the day, people with dementia tend to have a change in their behavior. So they may be very calm throughout the day, and then when 4 o'clock come, 5 o'clock come, they start to get a little bit more agitated or hyperactive or change in their character So that's what we call sundowning. So they may not want to sleep when they have sundowning, but it does not mean that it is a change in their sleep-wake cycle. So basically that happens. Most of the time when they have sundowning, then they may not sleep at night. So why sundowning happens? Nobody knows. There's no really scientific reason for why sundowning occurs. Some people feel that maybe later throughout the day it's a bit darker, people get a bit more confused like that lah. But there is no actual scientific explanation of why sundowning happens. I had a patient, I'm not sure whether I shared this before, it might not be very scientific, but then again, she was very sure. Every time when it's evening or every time when there is full moon, her mother will change in the character, become a bit more hyperactive. So she says she even buy the Chinese calendar to see when is the full moon, so she can be prepared, which is not unheard of, There have been research showing that when it's full moon, people, not just people with dementia, but maybe you and me, get a little bit more hyperactive. So if you go to discotheque or karaoke, the noise level tend to increase during those period of time. Not sure why, okay? So you go and find it out, okay? Yeah, but that's sundowning. Sleep-wake reversal is basically, they are awake most of the time during the night time, but then daytime they sleep now. So there's this reversal of sleep-wake cycle in people with dementia. Okay, so that's the two difference lah. So why is it disrupted? Not particularly just in vascular dementia. It can happen in any type of dementia. Again, why does it happen? We don't know. We think that it may be a disruption inside the hormones, but it may be also because they may not have a lot of stimulation during the day, then they fall asleep, then nighttime they cannot sleep. It may be a piece and parcels of those lah. Yeah. That's my answer to it. Okay. Any other questions?
Thank you,
That's it for now.
It is very difficult to manage also sleep-wake reversal, and many times family members were like, "Hey, can you give me some sleeping tablet, But yeah, so that's that lah. Okay.
All right.
Yeah.
Okay.
Yeah, this final few slides, I guess, Doctor, this is something I just took off of up to date in regards to a kind of like a algorithm for approaching an adult with altered mental status. I guess, yeah, we went through, there's like a whole list of things that we can think of, but I guess like we're covering dementia or even these, I'm guessing when they say UTI, pneumonia, these are all like possible causes of delirium, isn't it?
Yeah.
Yeah. Up here, down here. Yeah. When then these would be more, this is like alcohol withdrawal. No, this is alcohol related. This one would be diabetes, even sepsis, trauma, infections, as we mentioned. Yeah, I guess perhaps like even psychiatric illnesses, is it something important that, let's say if we are doctors on call, we see an old elder patient coming in with an altered mental status, like do we have to put this in front as well?
I think as for myself, to actually see someone with late onset schizophrenia, not very common. Okay, but I have a lot of patients who has midlife or young or schizophrenia as a diagnosis before and slowly develop dementia. Yes, very common, because having mental health disorder is a risk factor for dementia. So we now have a lot of patients in common now between us and psychiatry. Okay.
Yeah, that's interesting.
Yeah. So, but psychiatric illness in older person presenting as abnormal behavior, then it will still be your underlying cognitive impairment or major depressive disorder lah. Yeah.
Okay.
Like all this, your personality disorder, schizophrenia, like I say lah, not so common.
Okay. And then probably just this is something I took from our preclinical year notes as well. Very quickly, just run through Dementia Mimics. I would say that this is maybe like, Doctor, you want to explain this a little bit. From what I understand, it's that they are, because I think someone asked just now how you differentiate dementia from, say, depression or even from delirium, and the answer to that is actually it's not that simple, because they commonly overlap one another, or they are what's it called? Their presentations are pretty similar. So perhaps maybe, Doctor, maybe if you could be very, very, are there any specific questions that we can ask to a patient that can maybe kind of distinguish that this is more likely this rather than that?
you can ask them if they can answer lah. So usually, if you think that the patient may have depression, you ask them straight on, do you think you are depressed? If their answer is yes, then you'll be thinking, oh, it is very likely that they are depressed. Okay. But if you ask them, do you think you're depressed, and they don't know how to answer you, then it is not quite normal. So in terms that their cognitive, their reasoning skills, their cognitive function is not so normal, you'll be thinking, oh, okay, has this patient got dementia? But you can do all this. They are very clear cut in the actual literature itself, but as you say, like, in a patient, sometimes there's a mixture. But there are some things that are very obvious. So you have to see lah. Even in older person, mood, if they have low mood predominantly, think depression. Although sometimes depression can present in a lot of other somatic ways, like loss of appetite lah, GI effect lah, that kind of thing lah.
Okay. Yeah, I guess then perhaps just this one, poor short-term memory but no inattention, but poor short-term memory and inattention. Yeah, I guess is there like, maybe I'm just a bit nitpicking here, but I'm just curious, is there a reason why in dementia there's no inattention compared to delirium? Is there any...
Yeah, because dementia, because it's a chronic neurodegenerative disorder, like, so in a way, their attention to things are there, which is actually normal attention now. Because delirium is an abnormal acute problem, then therefore they have inattention because of disruption of probably acute disruption of certain chemicals in their brain system. So therefore they lose the ability to pay attention now. Yeah.
Okay.
Yeah, I think this is just to highlight that your dementia, depression, and delirium can coexist, and sometimes it's difficult to piece it out. But as you take a history and as you look after the patient, usually you'll be able to get an idea lah. Like I say, they may be depressed, they may be having dementia, but if there is an acute change to their condition, think delirium. So the acute change is very important now.
Okay, doctor.
Ian, I think you are muted.
Hello? Yes?
Yeah.
Sorry, so I was saying, this is just the last two slides on very quickly running through like the possible causes of delirium and dementia. As we can see just now, like considering all ages, this book has differentiated it into elderly and like younger patients, what might be the cause. So we have electrolyte disturbance, infections, and so on and so on. Doctor, is there like anything else that we're missing here, or we?
No, I think we are very thorough already.
Yeah, it's very thorough. Yeah. Yeah. So, but in regards to say HIV, yeah, yes, doctor.
I think because we've gone through a lot of different possible causes lah. So common things are still common. Although we presented a case of CJD, but not most of your patients are CJD lah. You're talking about less than 10% of the time.
Yeah,
but if you think about all the common cause, I think I think that would be good enough lah.
So in regards to the Malaysian context, what would be the most common causes that we must think about if we look through this table when we run through dementia, for say?
Oh, dementia. So if you talk about dementia, somehow at the moment, Alzheimer's disease is still the most common. But recently, we've seen also that vascular dementia is also very common in the Malaysian context. So those top three vascular dementia, Alzheimer's disease, and also a mix of both types, mixed dementia.
Okay.
but more importantly, you know, you need to make sure you know how to diagnose delirium and do not miss delirium. That is more important.
Okay, doctor. Okay, I guess that comes to the end of our session. Yeah, if anyone has any questions for Dr. Khor regarding any part of the topic, yeah, will feel free to ask in the comments or just unmute yourself and ask Dr. Khor. Thank you so much, Dr. Khor, for actually staying on board.
No problem.
Yeah.
They're all having their supper already.
Yeah.
Okay, I think it's really good you know, for yourselves, your MEDSOC to actually have sessions like this. And well done to you all So is this the 10th session already?
Yeah, doctor. It's basically our senior started it first, so we are kind of continuing it after a while. Yeah, after the last batch left.
Okay, good. Well done, you all.
Mm-hmm.
Okay, so I think everybody is so shy to ask question or so shy to challenge me. But you know, if you do have something that you feel, I don't think you're quite right, Dr. Khor, it's fine, you know. You can email me. So if you worry about coming straight to my face and say, I don't think you're right, you just email me lah. Okay? Then we can always discuss about it.
Okay. Yeah, I think most of I think the comments coming in are they're mostly thanking you, doctor. Thank you. Yeah. Not really any questions coming. But I do have one though, actually interestingly, in regards to probably dementia per se, like Alzheimer's, I understand that it usually affects short-term memory, but does it affect long-term memory in the early stages or like even down the line?
Usually the presentation is short-term memory. That's the most common presentation. As the dementia progresses, then only will it affect the long-term memory. So we're talking about at least you have to become moderately at the moderate stage of the dementia. Then you don't actually just lose your long-term memory. So normally how it does is that you lose a memory of things that happened recently. Then later on, as time progresses, you might mix up your long-term memory. So you might think that certain things that happened long time ago has just happened now. So you get it mixed up. Then after when you get it mixed up, you actually confabulate. You actually talk about things that actually never happened before. And later on, whatever you say, right, is totally, you know, not the real thing that has happened. That's when people actually start to lose the whole long-term memory itself. They basically not just lose them. When you lose your long-term memory and you do not have short-term memory, you then actually, can you imagine that not remembering things that happened before and not remembering things that happened just now? You feel that you're not yourself anymore, you know. So it's really a very sad stage lah. Yeah.
I understand.
And during that time, you also lose a lot more ability to do things for yourself. So we're talking of people, you know, progressing towards moderate to moderately severe dementia.
Oh, okay. We do have one new question, doctor. So Liaison is asking, is there something called intermediate memory and working memory? If yes, what are these?
This reminds me of Prof. Chin punya lecture. There was a lecture for about attention, and that Prof. Chin gave probably when you are in your second year. Okay, and basically, I can't remember what exactly is intermediate memory, to be very honest. Probably something in between. Well, definitely has to be something in between your short-term and your long-term memory Okay, working memory is how you process things Yeah. So, but if you want to know more about it, I cannot tell you. Have to look back in your lecture notes. There's many different types. You know, you talk about your semantic memory. You know, those are about things that you've learned before, knowledge and stuff like that. So there are many different categories. To be very honest, when we do our memory clinic, we have not managed to be so thorough in looking at the very specific details into each domain. We assess the domain, but we have got no time or no expertise to actually assess the details of each domain each domain in very much detail. That actually requires a neuropsychology testing but you know, we have not been able to engage those in a clinical setting, nor has anyone else in Malaysia that I know of lah.
Sorry, doctor, just to add on, when you mentioned those domains, you're talking about like is it the cognitive domains, is it?
Yes. So in your cognitive domain, you've got your executive function now, you've got your memory, you've got your visual spatial. But what we assess is, oh, can you do this? That's it. But when you do the actual neuropsychology testing, it actually takes probably an hour or 2 hours just to do that. So you want to know exactly like what Zhi Yong has said, which part of their memory is lacking. In terms of executives, what exactly can they actually reason? What's their reasoning skill? What is their abstract thinking? All that kind of thing lah. Yeah.
And so far, there's like no such what's that? There's our expertise has not reached that level, is it?
Well, in clinical setting lah, we should be doing it. In many places overseas, they do it. They engage psychologists to actually do that. But we don't have anyone hired to do it lah. At least in the clinicals and in the government setting. Yeah, even get a psychologist also so difficult. So in terms of that lah, yeah, we may not be as adequate and may not be able to have done as much as we hope lah.
I see. Okay. Yeah. Oh yeah. Thank you, doctor, for the session. This is from Khor Hui Min. So may I ask if those who are on a memory clinic follow-up, do they have follow-up in a psych clinic as well?
No lah, they discharge them to us. Okay lah, sorry. Usually, if they come to memory clinic, then we don't get them to go to psychiatry clinic. But if their primary problem, let's say they have underlying schizophrenia, like I've mentioned, or personality disorder, or bipolar disorder, and they're already seeing psychiatry, then we get them to continue, okay, to review them in terms of that aspect of their mental health. Of course, they are the expert. I don't treat anyone with bipolar. I'm not an expert in it lah. But if they start to develop memory impairment, then we see them. Actually, psychiatry also can see them, but they tend to refer to us because in older person, they have a lot of other issues as well. But if I've been seeing them and their psychiatric issue is now not as big of a problem, but their dementia is a bigger problem, then sometimes they get discharged from psychiatry. We just take over. Yeah. But if there's still ongoing issues, we continue to get them to follow up in psychiatry as well.
Okay. Yes.
All right.
Sorry, I kind of took over from Ken. Ken, have you got anything to say?
No. I mean, yeah, it's okay. I also look at the questions and I just see that.
Can I just laying back,
Well, I was also listening to the answers.
Okay.
It was like interesting.
All right.
Yeah.
Okay, so I think, sorry. I'll let the host continue.
Yeah, Ian, is there anything that we need to add for the closing?
It's okay.
Because I'm not sure.
You go ahead first. I'm planning. I need to put in the feedback form down in the conversation as well.
yeah, because we don't see any other further questions already. Yeah, and then doctor, is there anything you'd like to add on? So like,
no, I've been talking so much already. 2 hours.
Yeah, it's been a long session. So
yeah.
I think we have the feedback.
Okay.
Hey, wait, is that?
Yeah. So, okay. I guess that concludes our session. Yes. Well, thank you so much, Dr. Khor, again for coming on board on a Monday night. Yeah.
Yeah, this is the latest webinar I've ever done. But yeah, good job.
Yeah.
And thank you for being on. It's always a pleasure. I mean, to be very honest, we love it. We love it that students have this initiative, and we're more than happy to assist you, in any plans that you have. So do continue to carry this forward. There's a lot more you can do, to be honest.
Okay.
All right. Okay. Goodbye, everybody.
Okay. Good night, doctor.
Goodbye. Good night.
Okay.
See you.
Thank you.
Stay safe, doctor.
Okay. Bye.
Bye.